Picture this. You're sitting in a dead silent room.
Oh, I know where this is going.
Right. Maybe it's a high-stakes board meeting, or, you are taking a massive, perfectly quiet exam. You could literally hear a pin drop.
The absolute worst time for it.
Exactly. And then suddenly, without any warning at all, your stomach just lets out this massive, audible, whale-like growl.
The ultimate biological betrayal.
It really is. Everyone hears it, and you just have to sit there sort of hoping they all pretend it was an air conditioning vent or something.
You just want the floor to swallow you whole.
It is a universally awkward human experience, but actually, today's deep dive is all about that exact noise. We are exploring the sources you shared with us on bowel sounds.
Yes, specifically looking at how nurses and doctors assess your gastrointestinal function by ear.
Right. We are exploring the good, the bad, and the ominously silent.
Which is such a fascinating area to look into, because listening to the abdomen has been this untouchable cornerstone of the physical exam for generations.
Right.
But as your sources highlight, the science behind what clinicians are actually hearing and how much they should even trust those sounds is going through a pretty dramatic paradigm shift right now.
Okay, let's unpack this. Because before we get into why modern medicine is suddenly questioning this practice, we really have to establish what this noise actually is.
And who first thought to systematically listen to it?
Yes. And the sources point out this fantastic ancient Greek word that I just can't stop thinking about. It's borborygmus.
Borborygmus, it's such a great word.
Or borborygmi if you have multiple rumbles going on. It actually dates back about 2,400 years to the Hippocratic corpus.
Wow.
And it's literal onomatopoeia. Borborygmos. It just sounds like a rumbling, gurgling gut.
It really is a brilliant word. But to understand why the gut makes that borborygmi sound, we kind of have to look at the underlying machinery.
Okay, lay it on us.
Well, we have this tendency to think of the gastrointestinal tract as a passive pipe.
Like the plumbing under a sink.
Right, exactly, where food just falls down via gravity. But it's not. It is a continuous, highly active muscular tube.
I mean, it has to be to move everything along.
Yeah, it's lined with both circular and longitudinal layers of smooth muscle. And those muscle layers contract in these highly coordinated, rhythmic waves.
To push the contents.
Yes, the food, fluid, and gas, all the way from your stomach down to your colon. That coordinated wave action is called peristalsis.
And as that fluid and gas gets pushed through the tube, I mean, it doesn't just flow silently, right?
Not at all.
The sources describe how this material eventually hits areas where the diameter of the tube suddenly changes.
Like a bottleneck.
Exactly. A prime example is the ileocecal valve. That's where the small intestine empties into the large intestine.
Right.
When you force a mix of liquid and gas through a narrower space like that, you create mechanical turbulence.
And that turbulence is the key. The physical sloshing and bubbling of contents being forced through a dynamic, tightening tube. That's the actual acoustic wave you were hearing.
So the bowel sound is just the auditory byproduct of peristalsis.
You hit the nail on the head.
But for most of human history, physicians just heard the really loud rumbles, right? The borborygmi.
Yeah, the ones you can hear across the room.
Right. They didn't have a way to systematically listen to the quieter, everyday baseline operations of the gut.
Not until the stethoscope.
Exactly. René Laennec invented the stethoscope in 1816. Originally for the chest, but physicians eventually started placing it on the abdomen.
Naturally.
But what really caught my eye in the sources was how this became a validated scientific practice. It all traces back to this guy, Walter Bradford Cannon, in the early 1900s.
Oh, yeah. Cannon is a legendary figure in physiology.
He was at Harvard, right?
He was. And he wanted to prove that the sounds clinicians were hearing through the stethoscope weren't just random abdominal noise.
Right, he wanted to prove they meant something.
Exactly, that they were directly tied to the mechanical contractions of the gut.
I read the notes on his methodology, and it's honestly brilliant. He took cats and fed them meals mixed with bismuth.
Bismuth, right.
Which is a radiopaque contrast agent, meaning it blocks X-rays and shows up as this bright white shadow on an imaging screen.
So clever for the time.
Super clever. So he used early fluoroscopic X-ray imaging to watch the bismuth move through the cat's intestines while simultaneously listening to their abdomens with a stethoscope.
He was effectively linking the visual evidence of a peristaltic contraction with the auditory evidence of a bowel sound.
It's like the invention of synchronized sound in movies.
I think is a great way to think about it.
Because before Cannon's 1905 work, doctors were just listening to the audio track of the gut and guessing what the machinery was doing.
Right, they were just guessing.
But Cannon finally matched the audio from the stethoscope to the actual video of the gut contracting. He proved you aren't just hearing noise, you are hearing motility.
And because he provided that physiological anchor, auscultation, the act of listening with a stethoscope, became this mandatory, standardized part of the abdominal exam for nurses and doctors throughout the 20th century.
Which is a huge deal.
It is. And it introduced a very specific sequence to how a clinician examines you.
Oh, the look, listen, feel rule.
Yes, exactly.
The sources mention this. If a doctor or nurse is examining an abdomen, they are taught to inspect it visually, then auscultate with a stethoscope, and only after that are they allowed to palpate.
To press their hands into your stomach.
Right, to feel for masses or pain, they have to listen before they poke.
And if you think about the reactivity of the gut, that sequence is vital.
Why is that?
Well, if a clinician were to press deeply into the abdominal tissue first, they're mechanically stimulating that smooth muscle.
Oh, I see.
Or, say the patient has an inflamed organ. Pressing on it causes sudden pain.
Which triggers a whole reaction.
Exactly. It triggers a sympathetic nervous system response that can cause the gut to completely freeze up.
So you'd artificially alter the very peristalsis you were trying to measure.
Right. You need the baseline acoustic recording before you introduce any physical interference.
Okay, so the clinician listens first to gauge the baseline motility. And the sources break down what they are listening for into 4 official clinical classifications.
The tidy categories.
Right. Normal, hypoactive, hyperactive, and absent. And on paper, it seems like a perfectly organized diagnostic system.
It does. The clinical framework assumes a very tidy correlation between sound and function. Let's look at how textbooks define normal bowel sounds.
Okay.
Historically, medical literature has characterized this as intermittent gurgles and clicks occurring roughly 5 to 34 times per minute.
Okay, I have to stop you there.
I thought you might.
Because the sources dedicate a huge amount of time to dismantling that specific metric. The 5 to 34 sounds a minute rule is essentially just medical folk knowledge.
It really is.
It wasn't derived from some massive, rigorous, peer-reviewed clinical trial where they established a statistical bell curve for gut sounds.
Not at all.
It is literally just a number that got copied and pasted from one medical textbook to the next, generation after generation.
Which is wild when you think about it.
And there isn't even a consensus on the decibel threshold for what officially constitutes a sound in the first place.
It's a fascinating vulnerability in medical education. The clinical mind craves measurable parameters.
Right, they want a solid number.
Exactly. So when a specific number range appears in print, especially in a foundational textbook, it gets absorbed as an absolute biological truth rather than an arbitrary historical guideline.
That makes total sense. But despite that shaky empirical foundation, these 4 categories are still used daily to paint a clinical picture.
They are. Take the classification of hyperactive sounds.
Okay, how does that work in practice?
The classic real-world application here is gastroenteritis.
So like your standard viral or bacterial stomach bug.
Right. When the mucosal lining of the gut is under attack by an irritant or a pathogen, the local inflammatory response often triggers fluid to shift into the lumen of the intestine.
Because the gut is trying to defend itself.
Exactly. The gut's primary defense mechanism is to flush that offending agent out as rapidly as possible. So the enteric nervous system kicks the smooth muscle into overdrive.
You get hyperperistalsis.
Yes. The resulting sounds are incredibly loud, frequent, and turbulent. These are your hyperactive bowel sounds.
Which directly correlates with the physical symptoms, right? The gut is contracting so fast that the colon doesn't have the normal amount of transit time to reabsorb water from the waste.
Precisely.
Which is why hyperperistalsis almost universally presents with diarrhea.
The body is basically hitting the eject button.
And the stethoscope is just picking up the alarm bells. But then you have the complete opposite end of the spectrum, which is postoperative ileus.
Right, which falls under hypoactive or absent.
So what exactly is an ileus?
An ileus is a temporary paralysis of the gastrointestinal tract. It is incredibly common after abdominal surgery.
Because of the trauma of the surgery itself.
Exactly. When a surgeon handles, cuts, or manipulates the intestines, it triggers a massive local inflammatory cascade.
The body knows it's been invaded.
Right. Macrophages release cytokines, the sympathetic nervous system ramps up, and all of these factors combine to essentially tell the gut's motor function to go to sleep.
Just to facilitate healing.
Yes. The peristaltic waves just stop. So, if a clinician auscultates that patient's abdomen, they will hear very faint, infrequent hypoactive sounds or just total silence.
Okay, so that's gastroenteritis and ileus. But here's where it gets really interesting.
The mechanical bowel obstruction.
Yes. This is where the diagnostic reliability of the stethoscope gets really murky. Because an obstruction is not a static acoustic event, it's a dynamic progression.
It changes over time.
Exactly. Imagine a physical blockage in the small intestine, maybe a tumor or a twisting of the bowel or severe scar tissue from a previous surgery.
Right, something physically blocking the tube.
Early in the obstruction, the intestine proximal to the blockage, like the part upstream, realizes nothing is moving forward.
So it tries to overcome the physical barrier by contracting harder.
Right. The smooth muscle thickens and strains against the blockage, trying to force the accumulated fluid and gas past it.
And this immense physical pressure squeezing fluid through whatever tiny gaps remain creates extremely loud, hyperactive sounds.
The sources describe them as high-pitched tinkling or rushing sounds.
In clinical terms, yes.
But this is where I want to push back on the idea that the stethoscope is a reliable tool for this.
Go for it.
The sources emphasize that if the obstruction isn't resolved, those hyperactive rushes eventually disappear.
They do.
The bowel distends, the smooth muscle becomes exhausted, and the sounds fade into complete silence.
That's right.
So a clinician could listen at, say, 10:00 a.m. and confidently document hyperactive obstructive sounds. But a different clinician could listen to the exact same patient at 10:00 p.m. and document ominously absent sounds.
And the underlying physical emergency hasn't changed at all.
Exactly. The auditory data has completely flipped, even though the blockage is still there.
That dynamic progression is the fatal flaw of relying solely on auscultation. You are capturing a single acoustic snapshot, not the whole continuous movie of the patient's pathophysiology.
A snapshot, not a movie. That makes so much sense.
And your point about muscle exhaustion is mechanically vital. Visceral smooth muscle doesn't fatigue in the exact same rapid way that your skeletal muscles do if you are, say, lifting weights.
Right, it's a different kind of muscle.
But it does have a breaking point. When the bowel becomes massively distended upstream of a blockage, the stretching of the intestinal wall compresses the microscopic blood vessels supplying that muscle.
Cutting off the blood supply.
Exactly. That localized ischemia, the lack of oxygen combined with the prolonged mechanical strain, eventually causes the muscle fibers to fail and lose their tone.
Wow.
The contractions stop, and the loud tinkling sounds transition into silence.
Which brings us to the great rebellion currently happening in nursing and medicine regarding this exact practice.
It's a huge debate right now.
Because these four categories, normal, hyperactive, hypoactive, absent, they sound incredibly authoritative. But at the actual hospital bedside, the reliability of human ears interpreting these sounds completely falls apart.
It really does.
The sources cite a fascinating 2014 study by Felder and colleagues published in the Journal of Surgical Education. They essentially put the stethoscope on trial.
The methodology of the Felder study is what makes it so devastating to the status quo.
They didn't just ask doctors for their opinions, right?
No, they took high-quality digital audio recordings of actual patients' bowel sounds.
Okay.
Then they had a group of trained, practicing physicians listen to those exact same audio clips and ask them to classify the sounds into the standard clinical categories.
And the inter-rater reliability, which is the statistical measure of how often these highly trained professionals actually agreed with each other on what they were hearing, was shockingly poor.
Abysmal, honestly.
In some of the data sets, their agreement on whether a sound was normal or abnormal was only marginally better than if they had just flipped a coin.
Basically random guessing.
It's like taking your car to 5 different mechanics who listen to your engine. One says it's perfectly fine, and another says it's about to explode. How can this be a trusted medical standard?
Well, calling it completely useless might be a bit harsh, as it still offers some contextual clues, but the study absolutely proves that subjective auditory interpretation is wildly inconsistent.
Because there's no objective measurement.
Exactly. There is no digital readout for a bowel sound. It relies entirely on the acoustic limitations of the human ear, human memory of what quote-unquote normal sounds like, and highly subjective interpretation.
And because of that inherent unreliability, a major theme in the sources is the dismantling of clinical myths that have built up around auscultation.
There are quite a few of those.
Let's talk about the 30-second rule. There's this deeply entrenched idea where people assume a doctor can place a stethoscope on your stomach, listen for 30 seconds, hear nothing, and just declare you have absent bowel sound.
Which is a physiological impossibility based on how the gut operates.
Why is that?
Peristalsis is not a constant ticking metronome. It is intermittent. A 30-second window of silence could simply be a normal refractory period between contractions.
So they just caught it on a break.
Right. The strictly defined textbook standard to legitimately and legally document absent bowel sounds in a medical chart requires a clinician to listen continuously for a full 5 minutes per abdominal quadrant.
Wait, a full 5 minutes per quadrant.
That's the rule.
But the abdomen is divided into 4 quadrants. That means a nurse or doctor would have to stand at the bedside in absolute silence, listening to a patient's stomach for 20 continuous minutes just to verify the absence of sound.
Precisely. And in the reality of a chaotic, understaffed modern hospital ward,
nobody has time for that.
absolutely no one is doing a 20-minute abdominal auscultation.
So when absent bowel sounds gets written in a patient's electronic health record, it almost never represents a rigorously confirmed absence.
Usually, it just represents an unconfirmed temporary silence during a rushed exam.
That completely undermines the data in the medical chart. And speaking of the 4 quadrants, the sources dismantle that practice too.
The 4-quadrant myth.
Yeah, I've always seen clinicians move the stethoscope to 4 different corners of the stomach, but the physics of sound transmission actually render that unnecessary.
We have to remember the physical environment of the abdomen. It is essentially a densely packed continuous tube filled with fluid and trapped pockets of gas.
Right.
Acoustic physics dictates that sound waves transmit incredibly efficiently through fluid media, much better than they do through open air.
Okay.
So a rumbling contraction that originates deep in the lower right quadrant, say near the appendix, will easily propagate through the fluid-filled spaces and be perfectly audible in the upper left quadrant.
So listening in just one central location is enough.
Studies and modern clinical guidelines show that auscultating in a single central spot, usually just below the umbilicus or belly button, is completely sufficient to determine the presence or absence of bowel activity.
That's wild. So moving it around is just habit.
The ritual of moving the stethoscope to all 4 quadrants is driven far more by historical habit and the performative desire to appear thorough than by any actual physiological or acoustic necessity.
And then there's the final major myth the sources tackle, which is the concept of the surgical abdomen.
Yeah.
For a long time, there was this dogmatic belief that if a patient genuinely had absent bowel sounds, it was an immediate red flag for a catastrophic, life-threatening emergency, like peritonitis.
To understand why that was taught, you have to understand the peritoneum.
Which is what, exactly?
It's the thin, continuous serous membrane that lines the inner wall of your entire abdominal cavity and folds inward to wrap around all your internal organs.
Like a protective sac.
Right. If an organ ruptures, like a burst appendix or a perforated ulcer, highly irritating digestive acids or bacteria spill into that cavity, severely inflaming the peritoneum.
Yeah, that's peritonitis.
Yes. And the body's reflective response to that severe peritoneal inflammation is to instantly paralyze the intestinal tract.
Just shut it all down.
It's an evolutionary defense mechanism to stop peristalsis so the gut doesn't churn and spread the dangerous infection further around the cavity.
So in that specific scenario, the absent bowel sounds are an indicator of a major emergency.
They are.
But the sources point out that assuming the reverse is a classic logical fallacy.
Exactly. All patients with severe peritonitis might have absent bowel sounds, but not all patients with absent bowel sounds have peritonitis.
It's just a highly nonspecific finding.
Right. A completely silent abdomen might indicate a surgical emergency, but it might also just indicate a patient who is heavily sedated, receiving certain pain medications, or simply experiencing a normal lull in baseline motility.
So you absolutely cannot rule a life-threatening emergency in or out based on acoustics alone.
No. Clinicians have to look for tangible physical signs of peritoneal irritation, like an involuntarily rigid abdominal wall or severe rebound tenderness where the pain spikes when the clinician suddenly releases pressure.
So if the stethoscope is this subjective, this prone to physical artifact, and statistically unreliable, how is actual bedside medicine adapting?
Well, the sources highlight a major critique published in the British Journal of Nursing by Helen Bade in 2009 that really challenged the status quo.
And the primary battleground where this paradigm shift is playing out is in post-operative surgical care.
Yes, we discussed the postoperative ileus earlier. There has historically been a deeply entrenched nursing and surgical ritual surrounding this.
The feeding ritual.
That's the one.
A patient just had major abdominal surgery. They are awake, they're starving, they want to eat solid food.
Of course they do.
But the medical team is standing around waiting. The absolute rule was always, a patient is not allowed to consume solid food until a nurse formally auscultates and confirms the return of bowel sounds.
It was the gatekeeper to recovery. Wait for bowel sounds was treated as untouchable medical gospel.
But from a physiological and anatomical perspective, that logic is fundamentally flawed.
Because of the regional pacemakers of the gut?
Right, because different parts of the gastrointestinal tract wake up at different speeds after the trauma of surgery.
Exactly. The stomach and the upper small intestine generally recover their motor function and begin peristalsis within roughly 24 hours after surgery.
That's pretty fast.
It is, but the large intestine, the colon, which is way downstream, can remain paralyzed in a state of ileus for 3 to 5 days.
So a nurse could place a stethoscope over the stomach, hear plenty of loud, reassuring gurgles, and declare that the gut is fully awake.
They hear the noise and think, okay, good to go.
They give the patient a tray of food. The stomach processes it, pushes it into the small intestine, but then that food hits an absolute roadblock when it reaches the paralyzed colon.
Because the whole system isn't actually online yet.
Which leads to terrible outcomes for the patient.
The food backs up, the intestine distends, and the patient experiences severe nausea, vomiting, and delayed recovery.
And on the flip side, some clinicians would hear nothing and unnecessarily starve a patient for days.
Even when their gut was actually ready for clear liquids.
Right. Depriving them of the nutrition needed for wound healing.
Relying on the acoustic sign was causing patients to be fed either dangerously early or detrimentally late.
This realization has driven modern surgical departments to move away from the stethoscope.
Towards protocols called ERS.
Enhanced recovery after surgery.
Right. Rather than waiting for a subjective, isolated noise, ERS protocols demand undeniable functional proof that the plumbing is working collectively from top to bottom.
So what does this all mean? They look for clinical endpoints that cannot be misinterpreted.
And the ultimate functional proof that the entire continuous tube is open and operating is flatus.
Passing gas.
Passing gas.
If a patient passes gas or has an actual bowel movement, it doesn't matter what the stethoscope hears.
Not at all.
You have physical evidence that material is successfully navigating the entire length of the gastrointestinal tract and exiting the body.
ERS protocols aggressively de-emphasize auscultation. They focus on minimizing surgical trauma, getting patients out of bed, and walking as soon as possible to mechanically stimulate motility.
Yeah. Getting them moving.
Exactly. And doing early, cautious feeding trials based on whether the patient actually feels hungry and isn't nauseous, rather than waiting for an arbitrary rumble.
We are essentially watching a 2,400-year-old medical sign get actively downgraded in real time.
We really are.
It is moving from a strict diagnostic requirement to just an optional piece of background context.
It hasn't been completely thrown in the trash, obviously.
Right, because applying a stethoscope is incredibly cheap, it's non-invasive, and if you combine it with the patient's history and the rest of the physical exam, it still provides a tiny puzzle piece.
But modern evidence-based practice finally recognizes that bowel sounds are low yield and terribly low reliability when used in isolation.
It is the ultimate clinical snapshot, not the whole movie.
Beautifully said.
So to synthesize all of this for you listening, bowel sounds, those ancient borborygmi, are the audible acoustic signature of peristalsis.
They are the sound of mechanical turbulence as your smooth muscle aggressively pushes fluid and gas through a continuous tightening tube.
But the historical clinical practice of classifying them into tidy categories of normal, hypoactive, or hyperactive is highly subjective.
And the rigid rules passed down in textbooks often disintegrate when tested at the actual hospital bedside.
Which means the very next time you find yourself sitting in that dead, silent meeting room and your stomach lets out a massive room-shaking growl.
You shouldn't just feel awkward.
Exactly. You should actually appreciate the immense, complex mechanical turbulence of your continuous smooth muscle tube hard at work.
It's just your enteric nervous system doing exactly what Walter Bradford Cannon and his bismuth-fed cats proved it does over a century ago.
Such a great perspective.
And looking at the history of this practice raises an incredibly important question, something really worth thinking about long after this deep dive ends.
What's that?
Well, we just explored how the 5 to 34 sounds a minute rule, the necessity of listening to all 4 quadrants, and the strict ritual of waiting for sounds before feeding a patient were largely just medical folk knowledge.
Passed down as absolute truth.
Right. They were practices passed down blindly through textbooks for generations, until modern researchers finally stopped to test their actual clinical validity.
Yeah.
It makes you wonder, what other established everyday rituals in modern clinical medicine are highly trained professionals blindly trusting right now, just waiting for the evidence to prove them wrong?